In today's lecture, we're going to focus on joints. Specifically, these are the learning objectives for today. We'll focus on three main things. The first thing is the classification of joints, then the movement of joints, and then finally disorders of the joints. So let's go ahead and get started with the classification. Okay, so the first question we want to ask is, what is a joint? Well, a joint is a point of contact between either two bones, bone and cartilage, or bone and teeth. And a different word for the word joint is something called an articulation. The study of joints is called arthrology, and then kinesiology is the study of the movement of the body or the motion of the body. So what joint classifications exist? Well, there's two main categories. The first is something called an immobile joint, and there's two subcategories of this. One is called a fibrous joint, and an example of this is something called the coronal suture or the interosseous membrane between the fibula and the tibia. And notice that these joints are held together by tough fibrous tissue. Cartilaginous joints are another subcategory of the immobile or hardly movable joints, and these are held together by cartilage. An example of this is found in the hips and the pubic symphysis. And you'll notice that both of these types of joints here, if we sort of group these two together, both of them have no synovial cavity. And you'll see what this is in a second, the synovial cavity. And so this leads us to the second classification. So the second type of joint is a movable joint. And these joints have a synovial cavity. And so you're going to see these in a second, and they have a lot of accessory ligaments and structures that we'll talk about. So an example of this is found in the knee. You'll often see this in the knee. You can see that here's our synovial cavity. It has something called synovial fluid. You'll see that we have, a joint capsule. We have two articulating bones that are sort of leading into that capsule area. Okay, going back to that first category, we have these fontanelles in the skull, these soft spots. These would be the immovable joints. Just to sort of look at this, they all sort of start as something called anterior fontanelle or posterior fontanelle. Fontanelle is sort of the key word here. And then over time, what happens is these fontanelles sort of, harden, and they lead to something called a suture. So we can see that the anterior fontanelle eventually becomes the coronal suture. And you'll see this for all these other ones that are listed here as well. And this happens as, children develop into adults. So at birth, this ossification, to sort of summarize, is incomplete. These fontanelles, right, these loose connections between the bones allow for flexibility. The skull can grow. And then eventually, these harden and they become these sutures. Okay, let's talk further about the synovial joint structure, just to look at it a little bit. So you can see that we have our two articulating bones here. So we have one at the top, we have one at the bottom, and we have the periosteum, which is this outer covering of the bone. And then you'll notice that we have sort of three main parts here we want to hone in on. The first is that we have something called an articular capsule, and this is composed of the fibrous membrane and the synovial membrane. And this outer fibrous membrane is composed of dense irregular connective tissue. It's sort of a continuation of the periosteum. And then that synovial membrane, or the inner membrane, is composed of areolar connective tissue, a little more elastic. If we look at the second main part here, we have cartilage. And this covers each of the bones, each of the articulating bones. And this cartilage is made out of hyaline cartilage. And hyaline cartilage is something that provides sort of smooth contact, smooth surface of the bones so they can glide across each other. If someone loses cartilage, it actually becomes very painful as they age. The final thing we want to look into is the synovial cavity you see here. And it's filled with something called synovial fluid. And this fluid is secreted by the synovial membrane, contains acid, and basically it lubricates the joint. Okay, let's talk about accessory joint structures as well. The first one we'll talk about are ligaments. We'll talk about something called a meniscus. We'll talk about articular fat pads, talk about a labrum, and then finally something called a bursa or a bursa sac. So let's go and get started and talk about the first one here, these ligaments. Okay, so we want to ask ourselves, what's the difference between a ligament and a tendon? Well, really, both of these, right, are composed of dense irregular connective tissue, so they're not composed of cartilage. But ligaments connect bone to bone, whereas tendons connect muscle to bone. So if we look at sort of a diagram here, this is the knee, you could see where we have these ligaments here, right? So you could see we have the posterior cruciate ligament, the anterior cruciate ligament. This ACL is a common one that's torn in athletics all the time. See a nice little diagram of here. So This type of diagram, which ligament is which, we'll save that for lab. That's stuff that you're going to memorize in lab. But really here we want to focus on the difference between a ligament and a tendon, and know that both are made of this dense, regular connective tissue. Okay, let's focus on what a meniscus is. And if we look at a meniscus, really it's something composed of fibrocartilage. And really it's meant to cushion, right? It's meant to cushion a joint. And so you could see here that here we have a medial meniscus, here we have a lateral meniscus. And again, we're looking at the knee here, posterior view. And sometimes in athletics, these are things that have to be removed from an athlete because they're torn, they're dislocated. Not dislocated, but sort of moved around a little bit. They have to be, repositioned. And really what happens is sometimes they have to be removed and an athlete can function, but eventually that causes a lot of pain. And so the athlete sort of ages prematurely in terms of their joint at least. Okay, let's look at the next one here. There's articular fat pads. And these articular fat pads are basically sort of, cylindrical pieces of fat, right? And they're situated, in certain areas of the joint. And so the example I'm going to show you here is a certain fat pad that is basically behind the patella bone in the knee. And so you could see it sort of glowing in this image here. And again, helps provide protection to the joint, helps cushion the joint. Okay, let's go on to the labrum and see what a labrum is. And really what a labrum is it is this fibrocartilage lip that sort of extends over the socket of a joint. And really what it does is it helps keep a joint in its position so you don't dislocate, whatever bone is going into that joint. And so key areas you see this are in the hip or the shoulder. And really what they do is they help, again, help prevent that dislocation of that, bone from that joint. Doesn't always work, but that's sort of the idea. And so here we could look at the shoulder specifically, and we could see that we have something called the glenoid labrum here. And you could see it sort of extending, around the humerus, which is the bone coming out of the shoulder, right, going down into the arm. And it helps, maintain it there. It helps keep it in place. Also, we have something called a bursa sac, right? And a bursa is basically a sac-like structure that contains fluid, right, to reduce friction. And you also see things that are called tendon sheaths. And these are basically bursa that are sort of in a tube shape. And they, sort of encompass a tendon to reduce friction. A lot of times what can happen, you'll see these bursa sacs are sort of in blue here on your diagram. A lot of times these bursa sacs will rupture. I know I had it happen several times in my elbow in high school. And really, it's not too painful, but they sort of rupture, it's a slight pain. But then over time, the body just reabsorbs them. So it's sort of an interesting, phenomenon. But again, sort of meant to reduce friction, help the joints function properly. As always on this type of lecture here, all this diagram, all these different bursa sacs, those are things we're going to tackle in lab. So you don't have to memorize this chart here, right? You're not memorizing this chart, just to keep that in mind. Really, we're focusing on what is a bursa sac and what are tendon sheaths. That's what we're looking at right here for lecture. Okay, quick review to see if we're on the same page here. So what do you call movable joints? So think about it a second. And we call that synovial, right? They're not the fibrous or the cartilaginous joints. They're not those. So synovial. The ligament is made of what kind of tissue? So think about this one a second. Okay, dense, regular. What's the function of the meniscus? Cushion, absorb shock on the joints. And then finally, what's the function of the labrum? And the labrum, again, is to help prevent dislocation of joints, right? So that articulating bone that's going into that joint, we want to stay there. Okay, now that we talked about the classification of joints, let's go on to the movement of joints. Let's talk about that a little bit. Okay, so the types of synovial joints that we have are often categorized based on the movements that they do. So it's sort of nice, right? If you know the name of the joint or the category of the joint, really that is indicating the movement that it will do. So we have a nice little chart here. I want to point out a few of these here. So on the top right, let's start with sort of the obvious ones or the ones that make the most sense. So on the top right here, we have something called a hinge joint. And this is something that you'll see at the elbow, right? And it sort of swings back and forth. If you raise your, like you're flexing your bicep almost, that's sort of a hinge joint in action. Also, if we go a little bit, in a different direction here, but we look at the elbow again, right? We also have a pivot joint. And so you could move your forearm almost like you're opening a door, right? Like a doorknob, back and forth like that. You can pivot it back and forth in that uniaxial direction that you see here. So that's a pivot joint. Another type of joint is something you see in the hip or in the shoulder. And this is, sort of the most flexible, if you will, of joints, right? A ball and socket joint. And that has, multiple movements. Those are also, sort of a circular movement you can make with that. Those are also the ones that can get dislocated, right? Those are sort of the three main joints that I think are nice to take home from this page. Please do look over the other ones as well, but it's a little harder to describe the movement. You almost have to have it modeled for you. It's hard to show you in a lecture here, but we have a plane joint. We have a saddle joint. You're seeing these in the feet and the hands. We have a condyloid joint. And again, you're seeing that in the hands. The movement is much more subtle on those three, so a little bit harder to demonstrate. But these other three that I have here, the pivot joint, the hinge joint, and the ball and socket joint, I think those are ones that are really nice to compare and contrast. Okay, so what is something called range of motion, or ROM? Well, really, range of motion it's measured in degrees, and it's saying basically, how far can you move a given joint? And it helps show if you have proper function of that joint. It's influenced by a lot of things, right? It depends on the specific joint you're talking about. Certain joints have bigger ranges of motion than others. It depends on the tendons, the ligaments that are there. It depends on the tension of the muscle. It depends on, fatty tissue, hormones, and then obviously use and disuse. If someone's recovering from an injury, if you've ever, I know in high school I had wrist surgery, and after I had, basically that sort of cast taken off, I could barely move my wrist. And so disuse is really something that's actually quite bad for joints, and it takes a while, through physical therapy to recover that function. Okay, there's lots of movements that can occur at synovial joints, and here are sort of, four that you could see: gliding, angular movements, rotation, special movements. The next few slides, I'm going to walk you through each of these, and I want to show you, sort of what they look like. Okay, the first one is gliding. And really, gliding is a back and forth motion, right? A little change in angle, not much at all. I'll give you two examples. You can glide your jaw back and forth, and this is actually a movie. If you click on it later, it'll show you, but it goes back and forth in that direction. You can also move your hand back and forth, gliding it back and forth like that. Second type of motion is something called an angular movement. This is an increase or decrease at a joint angle. All the movements you see here are sort of in the sagittal plane in this picture, or you could be moving things in the frontal plane. It depends on what motion we're talking about here, but really it's a change in movement. So you could see it in your knees, in your hips, in your arms. Let's look at these a little bit further. So we could have flexion or extension. And really, if we have that, we're saying that if you, move your arm, keep it straight, but move it up towards your face, that's flexion. As you go swing it backwards, that's extension. And once you get past the anatomical position, right, which is right here, once you get past that, then you're talking about hyperextension. And you see those right there. Another type of movement or subcategory is abduction and adduction. And they look something like this. As you're moving your leg away from the midline, it's called abduction. As you're moving it towards the midline, it's called adduction. And I always think that you're adding it to your body, right? If you're bringing it down towards your body, you're adding your leg to your body. It's a good way to remember that. And all these movements occur in the frontal plane. There's also something called rotation, right? And rotation looks something like this. So if you keep your arm to your side and you pivot at the elbow, you can see if you're bringing your hand towards your midline, that's something called an internal rotation. If you're bringing it away from your midline, it's called an external rotation. There's also something called circumduction, a little more complex movement. And this is something where you take your leg and you're sort of swinging it in a circle, right? That's called circumduction of the hip joint. And really, this involves a lot of different types of motions in one. So you have flexion, extension, abduction, adduction, and rotation, all sort of in one. So circumduction is really a more advanced type of movement. There's also special movements that we talk about as well. You can move your ankle, inversion, eversion, and then you can do dorsiflexion and plantar flexion. They look like this. Inversion is, sort of moving the sole of your foot towards the midline. Eversion is moving the sole of your foot away from the midline. If you have plantar flexion, you're flexing your foot down towards the floor, for example. Inferior direction, right? If you have dorsiflexion, you're picking your foot up. So you're moving it in the superior direction. And I always think dorsal sort of like your back. So it's like you're picking your big toe and starting to swing it up towards your back. There's also something called pronation and supination. And this shows you the difference. And really a good way to remember these is supination is the movement you would use if you move your hand when you're eating soup. So it's that exact motion. So it's sort of a nice way to remember that one. Okay, the final thing we want to talk about here are disorders of joints. So let's focus on that. Well, there's many knee injuries that could exist, right? If we focus on that specific joint, very common to athletics, it's a good example to use. ACL tears are very common, happens in sports that involve twisting and pivoting, basketball, volleyball, soccer. There's a much higher incidence in females, and really the working model, as far as I understand it, is that it has to do with females having wider hips, and so the angle of their legs coming down towards their knees is a bit of a sharper angle, puts a little more tension on that ACL, makes it much more prone, towards injury. There's MCL tears. This is usually for a lateral blow to the knee, and it's also usually accompanied by some injury to the meniscus as well. And all of these are called the unhappy triad, right? Because they're the unhappy three, the ones that are most commonly injured in sports. So the ACL, the MCL, and the medial meniscus. There's some joint injury terminology we want to make sure that we know too. So something called a strain, and this is where you stretch or tear, right, a muscle or a tendon. There's a sprain, and a sprain is where you're sort of twisting or stretching a ligament, but there's no dislocation of bone. Sprains are very painful, or they can be at least. I've sprained my ankle many times in basketball. Very painful, actually. It takes a while to recover from that. Some people say it's even more painful than breaking a bone. I can't attest to that because I've never broken a bone, but the sprain is very uncomfortable, very painful. Some more joint injury terminology we want to talk about. There's a dislocation, right? And this is the displacement of a bone from a joint. And it's usually accompanied with tearing of ligaments, tendons, the articular capsule itself. An example is dislocating your shoulder. Happens all the time in football, all the time in basketball. There's bursitis, inflammation or swelling of the bursa sac. There's tendinitis, and this is inflammation of the tendon or the sheaths or the synovial membrane. An example of that is something like tennis elbow. There's also something that we call arthritis. And arthritis is inflammation of a joint cartilage, and it gets very stiff, sort of swollen. Osteoarthritis is the wear and tear form of arthritis, right? It's progressive loss of cartilage, and really it affects like large joints. So sort of these weight-bearing joints. Those are the ones that we really focus on. And you have a higher risk of arthritis depending on your gender sometimes, depending on your age. There's a genetic propensity towards it, obesity, and then previous knee injuries. So there's a lot of factors that contribute to these disorders like arthritis. Everyone is susceptible to any of these. You always want to keep that in mind. But when we say there's a propensity, it just means some people are more at risk than others. And this is sort of an example. You see a healthy knee on the left, right here, and then you see a knee on the right where basically that cartilage is just worn down and it's almost non-existent. You have bone on bone. Again, very, very painful. A slightly different form of arthritis is something called rheumatoid arthritis. And this is an autoimmune disease, actually, where the body attacks its own tissues. And really the cause of this is not fully understood. But it can be very painful. You can get loss of function. It's more common in women than men, and especially women over the age of 30. As I mentioned a second ago, cause really largely unknown, though I'm sure there's a genetic component. Stress could play a role, perhaps infections could play a role. And the interesting thing about this is that this rheumatoid arthritis really we notice this more in smaller joints. So you see in people's hands a lot, for example. Okay, the final thing we want to talk about in today's lecture is invasive surgery of joints. So let's just give you sort of an example of this. And the example I'm going to give you is a total knee replacement. So here's sort of a picture of a total knee replacement in action. You'll notice a few things. You'll see that the patella is removed, right? That bone that covers the knee, and it's replaced by a special plastic, right? It could be plastic or metal. The end of the femur is modified with a piece of metal. The end of the tibia is modified with a piece of plastic, right? That locks into the metal piece. And so really this is sort of you're reforming this joint, right? Either because, there could be many joint issues, obviously, but, maybe someone has bone on bone. It's very painful for them to walk. They need a walker. Giving a knee replacement can do wonders for someone like this, especially if they have other types of therapy or other types of actions they take. For example, if someone is maybe, perhaps a little overweight, losing weight can even further enhance the benefit they'll get from a knee replacement. And this is what it looks like if you take an x-ray sort of post-surgery, and you can actually see that knee replacement right in the x-ray, and you see it right at that joint. Okay, so those are the objectives that we talked about today. So we focused on joints, and then 3 main learning objectives, right? We looked at the classifications of joints, the movements, we looked at disorders, and as always, before you proceed to the next lecture, you want to make sure that you're able to execute all these learning objectives before you move on.